Good morning, good afternoon, and good evening, everyone, wherever you may be joining us in the world from today. My name is Francesco Del Carpio, and I am the CFL York Operations Coordinator. And I would like to officially open the fourth session of the Emergency Management and Hospitals and Healthcare Speaker Series with a land acknowledgement. We acknowledge and recognize that many Indigenous nations have longstanding relationships with the territory upon which our campuses are located that precede the establishment of York University. The area is known as Tkaronto and has been caretaken by the Anishinaabe Nation, the Haudenosaunee Confederacy, and the Huron-Wendat. It is now home to many First Nation, Inuit, and Métis communities. We acknowledge the current treaty holders, the Mississaugas of the Credit First Nation, and that the territory is subject to the Dish with One Spoon Wampum Belt Covenant, an agreement to peaceably share and care for the Great Lakes region. As this is an online event and our participants may be joining from various locations, I strongly encourage you to learn about the traditional land upon which you are located. With this, I welcome our moderator, our speaker, and our participants from around the world. Welcome to our webinar. Without further ado, it is my great pleasure to introduce our moderator, Mesha Richard. Mesha Richard is the current Emergency Preparedness Lead for the Thunder Bay Regional Health Sciences Centre in Thunder Bay, Ontario, Canada. In this role, she acts as a subject matter expert assisting with the development and maintenance of emergency management governance, training materials, and exercises. Misha also volunteers as an editor for the Canadian Journal of Emergency Management and is happy to be a collaborator and facilitator for the CFL York series. She holds a Master of Disaster and Emergency Management degree from York University and bachelor's degrees from Western University and Brandon University in the focus areas of political science and disaster studies. Misha, thank you very much for moderating today's session, and the floor is yours.
Good morning, everybody. Thank you for that introduction. Happy to see so many familiar names popping up for attendees. I'll start off by doing just a little bit of basic housekeeping before I give an introduction to our speaker today. So one is you'll notice that our webinar chat is open. However, the chat's not going to be monitored for any of your questions. So if you do have questions, please put them into the Q&A format, and I'll be checking that tool and addressing the questions as we go. There might be a few moments where we can pause throughout our presenter's presentation, but we'll see. And ultimately, we'll make sure that we have enough time to take up some questions at the end. So again, please feel free to populate as many questions as you have in the Q&A and keep the chat discussion going on the side separately. So with that little bit of basic housekeeping, I'll get to introduce Andrew Moull, who's our speaker today. So Andrew's been involved in healthcare emergency management since 2014. So this is almost a decade of you being on this side of the industry, Andrew. And he is currently the manager for emergency and disaster management at Hamilton Health Sciences in Hamilton, Ontario. In addition, he's currently a co-course director for a York University Disaster and Emergency Management Graduate Studies program, teaching emergency management in healthcare since 2019. Andrew sits on several committees for the Association of Healthcare Emergency Preparedness Professionals, including the Education and Resources Committee, and is a passionate believer in bringing healthcare emergency management professionals together to collaborate and advance best practice in the industry. So Andrew has also completed 2 master's degrees. His first was in history at the University of Waterloo, and his second degree in disaster and emergency management was from York University. So Andrew, thank you so much for taking the time to help us out with this series and being one of our presenters. Very excited to hear you talk about today's topic of temporary patient housing. So thank you, and take it away.
Perfect. Thank you so much. Thank you for that introduction and reminding me I'm 10 years into this field already. I'm just going to share my screen here. I want to make sure, and the screen looks good. Presentation's not on the presenter mode. Fantastic. All right. Officially good afternoon, everyone. Thank you all for coming today. Today, as you all know, we're going to be talking about temporary patient housing, which is something over the last couple of years I've gotten to know much more intimately than I think I ever thought I would, certainly due to the pandemic. So without further ado, I'll get started. So just a little bit of background, and I did notice a few of our friends from the US in the attendees list. So for those who don't know, Hamilton, Ontario is located at the corner of Lake Ontario. We're not part of Toronto, and we'll fiercely remind folks of that. and we're nestled just in the Golden Horseshoe in between Niagara Falls and Toronto. Hamilton Health Sciences, we have 10 sites overall, 5 hospitals and 5 outpatient and clinic facilities. This includes a level 1 adult trauma center, a children's hospital with a level 1 pediatric trauma center, community hospital and cancer center, a regional rehab center, rural hospital, a non-acute hospital, urgent care clinic, pediatric outpatient clinic specializing in autism care and prosthetics, and a research institute. We are host to Canada's largest NICU with around, I think, 83 isolates for babies. Canada's largest youth mental health unit, inpatient unit, and also Canada's largest palliative care unit. We also are a regional center for trauma, cardiac, neuro, burns, stroke, pediatrics, and advanced cancer care. Not done. We have around 1,200 funded acute care beds. When we factor in our hallway medicine and our non-acute beds, we get up to around 1,800 in total. We have 13,000 full-time, part-time employees, as well as 2,000 physicians and 1,200 volunteers. We serve a catchment area of 2.4 million people, and we are also a research and teaching hospital partnered with McMaster University here in Hamilton. And so with that background in mind, when we look at temporarily housing patients, there's a number of considerations that come into play. So first and foremost is, what's your rationale? Why are you doing this? And that's a really big and important question to ask, because you're likely going to be taking patients out of an acute care setting that is specifically designed to care for these patients into what is likely a non-acute care setting. And so there's a lot of inherent risks in that and a lot of work. So it's really important to understand what your rationale is behind this. Typically, it's because the ability to provide that adequate care to patients has been compromised. And so this can be through infrastructure failure, or the facility might be compromised. We saw this with any fires to major hospitals. We had this experience in 2017 at our St. Peter's site, and we had to temporarily house patients in other areas around the city and other hospitals, but also from sustained patient volumes that are well above hospitals' capacity, and a pandemic is the perfect example for this, especially if it's a prolonged event. We also need to assess whether or not we can provide a safe space for patients or alleviate pressures on ICUs and hospitals during these major surges. So if you need to open a release valve in terms of pressure, these alternate temporarily spaces can be very useful. And it really should be a last resort. I always say, my students will know this, my colleagues will know this, when we look at either evacuating or moving patients, we want to do the minimal effort, just because of the risks inherent in moving patients around, especially the higher level of acuity you go. So in a lot of ways, non-traditional facilities are unable to provide equivalent care. They just don't have the infrastructure. They're not built that way. Certainly a lack of traditional safety systems. Hospitals fall within a different category in terms of fire code, and there's expectations and annual training and inspections that have to take place, as well as there might not be access to emergency or critical care for your more acute patients. Where in a traditional hospital, they might have those response teams or pharmaceuticals or anything like that on hand. And they can also be really expensive, like mind-blowingly expensive to get to open one of these temporary sites and also to sustain them. Other thing to consider, location. So it does need to have the adequate space, not only for the number of patients you're looking to care for, but also all the accompanying logistics. And so it needs to have adequate power and the infrastructure needs to be able to support that demand, that increased demand, as well. Likewise, the adequate plumbing and sanitation, which when we were, I'll go into this more in depth later in the presentation, it came up a lot when we were looking at possible spaces. Safety systems, fire systems, make sure there's access and egress routes in case you did have to rapidly move patients in and out, and as well as security systems, both to protect patients from any external threats, but also to make sure patients don't go wandering out into harm's way. And then you have to have that debate. Are you going to use an existing structure, so a convention center like the picture from here, or hotels, or are you going to go with a temporary structure such as a field hospital? And there's pros and cons to both. I've had, fortunately or unfortunately, depending how you look at it, experience with both, and both have their positives and both have their challenges as well. Next consideration you need to make is, what patients are you going to be temporarily housing? In an acute emergency, this may not be up to you. It might just be the fact that your medicine unit, for whatever reason, is unable to provide care. So you're going to be housing medicine patients, or ICU might be compromised. In an acute rapid evacuation, you don't necessarily have that decision. In a pandemic, and when you have the planning and time in place, you do need to really sit down and determine what you want to do with this space. Who are you going to serve? So are you going to care after acute patients? Is the demand there that this temporary space needs to be able to support acute care? Is it going to be a step down? So those folks who could be discharged in the next day or a couple of days, and using that as a release valve for pressure within the hospital, so you can have more acute beds available within the existing hospital, or alternate level of care patients. So patients who really don't need to be in the hospital, but due to lack of long-term care space or home care availability, are still they still require care. They just don't need the acute care. And if you're ever wondering, one of the big reasons why wait times in emergency departments are so long, number of ALC patients is a big reason, because it just has a domino effect. Are you going to quarantine infected patients? This was a huge debate that we had. I've seen things go either way with these types of facilities. Typically, though, if you're going to go all in, you have to go all in one way or all in the other. You're either going to only treat infected patients, or you're going to try your best to keep the virus out of that facility and treat non-infected patients. And then as well, you have to do a risk assessment. So looking at wandering risks. So how likely are patients potentially going to wander offsite, as well as behavioral risks. So violence in healthcare is unfortunately an epidemic that probably needs to get talked a lot more about. But we do need to factor that in this decision making, because again, the resources that you may have on hand in a hospital, you may not have in a temporary facility, and that includes access to security or trained staff who would normally respond, say, to a violent patient or a violent person incident, might not be there in this temporary facility. So you have to take a look at your behavior risks as well. Operational supports. So all these things you have to consider. Facility management, so all your infrastructure, your utilities, security and patient safety, your food service. So how are you going to be bringing food in? How is it being prepared on site? Are you going to just have a kitchen operate on site? Your supply chain. So does the facility have loading docks? How are you going to get your resupplies? And you do go through a lot. Your laundry service, linens, scrubs. Laundry is a huge factor for hospitals. Your environmental services and waste management, and then as well your infection prevention and control, all need to be factored in. So once you get kind of identify your clinical approach, now you have to start looking at, okay, how are you supporting clinical operations? And you have to go through all this long list of operational supports. Then we get to staffing, and this, I think, is coming out of the pandemic, is certainly one of the continuing challenges. But you can have as many physical beds as you would like. You can have 1,000 beds. If you don't have the staff there, it doesn't matter how many beds you have. So when looking at staffing, you need to look at your required specialties. So again, what level of care are you providing? This is going to dictate what specialties in terms of staff you'll need. So if you are going to be providing more acute care, if you had to provide, say, intensive care, which could be done temporarily, but you need those ICU nurses or trained folks, or do you just need RPNs and RNs and maybe a general practicing physician? Then you look at your available staffing resources, which during a pandemic and post-pandemic is very well known in the system. And so again, if you don't have the staffing resources, you're not going to be opening a temporary facility. It's just as simple as that. You're going to stop your planning right there. So then we look at our clinical staff. How are you dividing that up between, say, nurses? Do you have pharmacists you need on site, physicians? You need allied health, so physiotherapists, things like that. As well, then you go into your operational staff, so your logistics, security, environmental services, and then your admin staff. So how is this site going to get managed? Patient flow in and out of the site, and then as well education and training. So in healthcare, we have constant ongoing training across multiple spectrums, including emergency management, but also just typical best practices of care and routine training. So you do need to have that baked into your temporary facility as well. So with all that in mind, I'll go through what our experience was, both with our satellite health facility, affectionately known as the hotel, and our experience with a field hospital. So for the satellite health facility, very early on, we recognized that this was going to be a need, and that was largely through observing what was going on both in Italy at the early stages of the pandemic. We'd been monitoring COVID since mid-December, late December, so a bit earlier than I think a lot of folks. And that's just from we maintain a biocontainment response team within the hospital, so we're always keeping our heads on a swivel in terms of emerging infectious diseases. And so once we started kind of seeing the demands, China a bit, but certainly once Italy and New York was very vivid, leadership started recognizing that this would likely be needed for us, and we started looking around to see what we could do for temporarily housing patients if the demand got to that point. We also knew prior to COVID, our system was incredibly strained. And so we were already regularly at 105, 110%, 120 wasn't uncommon percent capacity. And so we didn't really have a lot of breathing room as is. So we were incredibly vulnerable to a large sustained surge, and just seeing what was going on with our counterparts around the world. It was deemed probably in March 2020 that we need to start planning for this. So the search began for a location. We decided fairly early on we were going to look at existing structures. We had thought of doing a temporary structure initially and reaching out to NGOs such as Global Medic for experience, and EMAT, the EMAT team as well. So we checked out the Hamilton Convention Center, which is what the picture here is depicting. And if we were going to have that kind of typical rows upon rows of beds for that very large surge, we looked at local hockey arenas, which we have in abundance. We actually designed our drive-through testing to operate out of a hockey arena as well. So we were familiar kind of with a lot of functions of how an arena could support what we wanted to do. We did check the Sheraton Hotel, very lovely hotel. and nearly took on the role. But we settled on the old Crown Plaza Hotel in Hamilton. It did have the required space for patients and operational supports. We kind of got the green light that we'd be able to stay there for a prolonged period, knowing that pandemics typically are multi-year events. We partnered with our sister hospital in Hamilton, St. Joseph's Hospital. So we would take the first 4 floors, they would take the top 4 floors. And the reason we chose the Plaza Hotel, say over the Sheraton, is the Plaza Hotel would let us renovate. That was a key decision because as we'll see, hotels are nowhere close to being healthcare facilities. They need a lot of renovation. Hotel beds are not hospital beds, so we had to take all the hotel beds out. Interesting fun fact is a standard hospital bed will not fit through a hotel door, so we had to go and find some vintage hospital beds that would fit and are permanently now in those rooms. The washrooms had to be completely redesigned and to facilitate more accessible use, especially for older patients. All the carpets had to go. Anyone in healthcare knows carpets, infection control will always remove carpets. And then in my role, patient safety systems, we worked with our safety department to get call bells installed. So patient call bells, fob access to the elevators, because it would be very easy for patients to just hop on the elevator, take it down and go first roll or get out of the facility. And likewise, alarms on stairwells for the same purpose. And there's still a long list of upgrades we're waiting for funding and approval. Currently, the smoke alarms are your standard home smoke alarms in the patient rooms. They're not linked to a central system. So we've had to navigate and some accommodations with Hamilton Fire Department in terms of that. But I think we're going to have to get that centralized backup generator. There's no backup power for this facility. So ideally, like I said, you're not necessarily going to have all the functions you would in a normal hospital. Certainly the case with the hotel. So the picture here is of the charge station. You'll notice has a lovely fireplace in the center here. And just off to the right of this picture is a beautiful jacuzzi tub, which came in handy when we had a sprinkler head knocked off a floor above one of our floors. And fortunately, all the water funneled straight into the tub. So we're very happy that we kept the tubs in place. So we went with ALC patients for this site. We figured we could really free up a lot of acute space. They're the most appropriate. They don't necessarily need the acute care. So we didn't need critical care teams for response, say for cardiac arrest or anything like that. We have AEDs and rely on Hamilton paramedic services. But ALC was the easiest, and it would do the most good for our response. It freed up a lot of acute beds, and still has. So it's still open. The hotel is still open, and the temporary status is actually being removed, both by the fire department and city planning and the province. And so we do have a funding decision coming up in the future. But one of the key things, and this is a bit of a lesson learned, is in terms of the recovery challenge is I would love to close the hotel down. Ideally, this isn't a healthcare setting. I'd like to move patients out of there. Although apparently a lot of them do like being cared for in a hotel. The patients do actually are enjoying their time here. But from a safety standpoint, I really want this to be something we don't need to rely on. The problem is, where are you going to put 300 ALC patients? And so that recovery planning, I don't know how much we can do, just given the limitations within the system in terms of finding adequate care space for these patients. but I think we probably could have done more to look at how we could start moving through that decommissioning. And so with it being the temporary status coming to an end, the building will need to be brought up to code. So it's getting that funding for getting all the, if we are going to stay here for a while, getting all those safety systems up to snuff, and a lot of work ahead. So this is the hallway of the floor. You'll notice this is a much narrower. Anyone who works in a hospital, you'll notice how narrow these hallways are. We do have a vertical evacuation drill we have to do for our fire department next month, and demonstrate the use of evacuation equipment. So it'll be very interesting to do. We've done some smaller trainings around this, but to do the full-fledged evacuation of a floor will be quite interesting to see in terms of space management, how this all works out. But a lot of interesting quirks of a hotel. The doors also don't stay open on their own. So trying to negotiate with the fire department about propping doors open, it's been an ongoing debate. On the other side of things, we did get to establish a field hospital at the province's direction. So back in February 2021, the province directed us, as well as Sunnybrook, to establish field hospitals in anticipation for the next wave. Sunnybrook got the orders first and began their construction earlier than us. And our targeted opening date was May 2021. Physical planning began first with resurfacing the parking lot. We realized if we put it on the parking lot as is, there would be a lot of infrastructure problems with the tent. And so we had to completely resurface the parking lot. But then we started adapting a similar planning process from the satellite health facility. So that was really helpful, that we could take a lot of those lessons and a lot of those considerations that we'd made for the satellite health facility and apply it to the was called the mobile health unit. I affectionately called it Camp Steeltown. So with our planning process, we had to bring in a whole bank of generators that were on a daisy chain of redundancy. Had to get a full water bladder in to provide clean water for the hospital. Fencing had to go up for security. And so took about a month and a half, 2 months of construction. So these field hospitals, I know the military does have some capacity to quickly throw something up, but typically you don't have, it's not something you can just, oh, we need this right now, let's get it deployed, and by tomorrow we'll have a field hospital. These things take quite a bit of time and work to put in place. So here's some pictures of the deployment. So took up a good chunk of the parking lot, which created our other issues down the line in terms of finding parking spaces for our staff who traditionally would be parking in that lot, as well as making sure bringing our emergency services in. I brought them in right away. They were very excited to come and tour the site, but we did have to bring a fire truck in to make sure that it could have access to the whole perimeter of the fence. EMS came, and when we did training as well, we would include our first responders in the training, but that also gave our staff members their realistic time on how quickly they could respond. So the picture here with the nurses doing compressions, they got a really good sense of how long they would need to be doing compressions before paramedics showed up, because for a number of union reasons, staff coming from the general hospital, which is right beside this field hospital, would have to cross several streets, which is a safety issue, plus bringing all the equipment. So we were going to rely on EMS. So it was great to create that realism. And then we went through the whole gambit of emergency codes and procedures. And we never actually had any patients in this tent. So By the time this opened, the Delta wave had started to come down. We were moving away from those frightening moments where we were staring down crisis standards of care in our critical care areas. And the pressures were easing off. And so we were going to use this as a step down. So not ALC like the satellite health facility, but we were going to do a step down model to free up additional space. So we'd have the ALC at the satellite health, and then we could use the field hospital as a step down. And the staff who did sign up for the mobile health unit were desperately needed back in the hospital. So it didn't make sense to sustain the field hospital. Although I will say, come the Omicron wave, it probably actually would have been handy to still have this. We ended up tearing it down in the fall of 2021. But come winter 2022, actually probably would have been handy to keep around. So when we look at the lessons learned, I always joke with my wife, I'd be remiss if I didn't include a Walt Disney quote, but Mr. Disney was a big proponent of constantly changing and learning. So couple things that really have been lessons learned and are becoming lessons applied is when you're looking at temporary housing patients, you do need to look at having actionable frameworks with pre-identified sites being incorporated into your pandemic plan. There's a lot of, I think, changes to how we do pandemic planning that need to happen. But one of them is that we do need to just assume that, temporary housing to patients is likely going to be a requirement. And so having those frameworks in place doesn't need to be ultra detailed, but having those frameworks in place, as well as some pre-identified sites, is very important. And then really making sure leadership needs to make the decision in the early stages. So we did do that with the satellite health facility. We were dictated for the mobile health unit, but in hindsight, at a provincial level, that decision should have been made earlier in 2020, so that the facilities would have been. I believe Sunnybrook did take several dozen patients in their tent, but our tent would have been useful in the peak of Delta, but it wasn't built yet. So had the decision been made earlier from the province, it would have come in handy, and even earlier in the pandemic. So I think right at the kickoff of a pandemic, the powers that be need to start making decisions and identifying where temporary housing can go up in communities. Appropriate staffing availability will just dictate whether or not temporary patient housing is feasible. It's as simple as that. If you don't have the staff, you're not doing it. This wishful thinking otherwise. And then once you do get it in place, you need to have that robust training for staff working in this environment, especially if they're from the hospital, because they're used to working in that hospital environment. They're used to having all those supports. And so from an emergency standpoint, we went through everything and said, no, you don't have that now. This is how you have to adapt. And the onboarding was quite robust. And I'm at the satellite health facility every month now, doing ongoing training. And we're looking at expanding some of that training as well, as more and more new staff come on board there who don't have any previous hospital experience. So just having that new staff, but you do need to make sure that you have that training in place to support those staff. And that is all I have.
Excellent. Okay, so this allows us a little bit more time for questions than some of our other sessions. And I was rapidly typing some notes to direct towards you, Andrew, and you did answer a number of them throughout the presentation. But I will say we did end up having a couple of questions come up explicitly tied back to fire safety.
Oh, perfect.
And as you pointed out, like these are facilities that aren't sprinklered and don't have tied in alarm systems. And so for anybody in this call that works in healthcare, thinking about that is almost overwhelming. There was a comment made, was there fixed oxygen supply at these locations or other gases or fuels that would have increased that risk of fire? And so how are you working on fire prevention in a space like that? Are you doing hourly fire watches? What does fire safety look like in a facility like this?
Great question. So I'll do I'll break down to two parts. So with the hotel, thank God Canada actually has very robust fire codes for most facilities. So the hotel is thankfully sprinklered, and does have pull stations. And so there is a central bell system. It's just the smoke detectors aren't tied into it. So with staff, when we do the fire drills on those floors, we actually trigger the smoke detectors. So they do get familiarized with how it sounds different from a patient call bell, as well also getting used to the acoustics, because the acoustics are not great. And if that door is closed or even moderately propped open, it's even worse. So really working with the staff to identify it, and emphasizing that situational awareness with them. As well as, again, thankfully with our building codes, the hotel's a concrete block. So a fire, as long as that door gets closed, it should be contained to that room. And there's no oxygen for the hotel. And that's one reason why we went with ALC patients, and even instead of step downs, because some step down patients do require oxygen as they recover. ALC patients is that minimum level of required care. So we just removed that hazard, because that would be a challenge. When we worked with the mobile health unit, it actually, the tent was fire retardant material, which the second I was told we were making a tent, fire safety immediately started going off in my head. But the company that we were working with, it was a very, very, very nice tent, and it did have an integrated smoke alarm, and we used portable oxygen. So again, it would be similar fire safety considerations to in a hospital, when you're looking at portable oxygen, and just getting it out of the space if possible. I don't believe it was sprinklered though. And you don't have municipal water systems, so a sprinkler system within the tent, I don't know how long it would last. I guess would be on the bladder, which did hold a lot of water, but depending on what you needed, I don't think it would work for the fire safety. So I mean, the tent had some features that the hotel didn't have, and the hotel had some features the tent didn't have. But it's a challenge. And the other challenge too, and again, for folks and especially Ontario hospitals who have to do annual vulnerable occupancy evacuation drills, there's no fire break on the hotel floor. So there is no horizontal evacuation. You're going vertical as your first stage, which is never an ideal option. Like I said at the beginning, minimal effort. I want to only move patients as minimally as possible, and taking patients down stairwells always comes with risks, both for patients and staff, even with equipment. So unfortunately, that is the circumstance we have in the hotel. For the field hospital, we just ran them out the back door. Each pod had a back door. So we had, if for whatever reason the main tent hallway was compromised, we had egress options in every pod. A good question though.
Yeah, I was going to say it's a multifaceted one, because when you were showing the width of the hallways and talking about having a drill, it's those sorts of considerations. So I did want to touch on something myself. I know there's a couple of questions I think that are popping up in the chat right now, but a lot of these considerations that you were sharing with us as far as determining some sort of temporary patient housing space. So aside from setting up the field hospital, but trying to pick an alternate location. I think clearly there's a lot of takeaways for attendees on the call as related to even making selections for Code Green, which for anybody that joined sessions 2 and 3 in this series, we did focus on Code Green, which is evacuation in our hospitals. So Andrew, I'm curious if any of these considerations were items that had stemmed from Code Green evacuation discussions at the hospital, and in what ways you might not be leaning on those same plans.
Yeah, well, I mean, the time it takes to establish these facilities, I think, negates a lot of their use for evacuation. We do have a very robust Army military reserve who would probably support us if we absolutely begged them in Hamilton. But I think because of it really didn't factor into our planning, and I think that's mostly because one, Southern Ontario is I think has the highest concentration of hospitals in the country, and so from internally, when we had the St. Peter's fire here, we just evacuated mostly to our other sites internally. So from St. Peter's, they went to the Dravinsky Cancer Center, they went to the General. And then we've worked closely with our long-term care partners as well. We have a memorandum of understanding with them. I mean, I think with an evacuation, you really want to build those relationships with other hospital organizations and those partnerships, because in a pinch, they're going to be the ones who may be able to assist and provide. And then you also have the appropriate level of care and expertise within those facilities. So actually it didn't, from an evacuation standpoint, it didn't factor in too much. Now, that being said, when you're looking at, say, Yellowknife's experience, where it's a more planned evacuation, I believe they did also work with partner hospitals in BC and Alberta to look after patients, was my understanding. So I think from an evacuation standpoint, now, in the midst of a pandemic, and I've raised this concern, I mean, it's probably still a valid concern now, is if we had to evacuate a hospital and everyone's at 100 and 120% capacity across the system, that does raise some questions, and you'd probably be looking at rapidly establishing one of these temporary sites. You probably would reach out to the military. I'd probably be calling colleagues across the border in Buffalo and in New York State to potentially come up and help. But it comes down to I think prioritizing those partnerships with other hospitals versus maybe relying on or banking on setting one of these sites up. Just the time it takes is you're looking at months, weeks and months, not days.
Yeah, certainly. I think it had highlighted a couple of pieces when you were sharing, again, hospital widths, doorway widths, elevator usage, those sorts of things. So again, even for anybody that's on the call, when we're thinking about some sort of evacuation at one of our facilities that might have us pushing out to one of those MOUs that we have for a university across the street or something like that, that those logistical considerations we have to keep in mind. But obviously, as you mentioned, the time frame involved. So I did have a question pop up as well saying, how quick, I think you might have sort of answered this a little bit as far as bridging between an evacuation versus, as you said, sort of a prolonged surge scenario. Somebody was saying, how long do you think it would take to set up temporary housing for more acute patients? Because I think before you had mentioned, if it's something like the ICU, because it sounds like with the pandemic, we had a bit more time, you had this lead time to kind of consider, but we might have to set up something like this a bit more urgent, having temporary housing for more acute patients.
Yeah, that's I mean, the mobile field hospital did have limited critical care capacity. If you had to, you could do it. Again, getting the oxygen supply would be tricky, and managing, you'd be using temporary oxygen a lot. I am aware, though, I believe there were some organizations who have done more acute patients. I think the timeline would be similar. It's more your procurement of those resources. And so if you've got more acute patients that require more resources or more specialized resources, it comes down to how quickly can you order those additional resources. You're obviously not pulling them from your site, because I'm assuming you're making this call, your site's stretched thin. It really comes down to can you safely provide that care? And ideally, again, you'd look back at those partnerships for your more acute patients. I'd be very cautious to put an ICU patient in a temporary housing. I would do absolutely everything possible to get them into a hospital who might have capacity. But you'd be looking at, I mean, outside of a forest fire situation where you did have to evacuate the full site, from a prolonged pressure standpoint, I'd be going through every unit to a step down or, a medicine unit, so then I could use that previous medicine unit, which has oxygen flow and things like that, as a temporary ICU. So I'd be expanding ICU capacity within the hospital before looking at moving those types of patients out of the facility. They would be the absolute last to go. And then if it was a rapid situation, I would be working with other partner hospitals to see if they can take some of the patients in their facilities.
I was going to follow up when you had commented about trying to review with staff how long it was going to take for EMS to respond in the tent for something that we would consider to be a code blue for some folks that are on the call. So essentially like a cardiac response. But what about some of the other code responses, and how do you handle those when you don't have a PA system or the same type of alarm system, and just some of those additional considerations? So for folks in attendance, if we're saying code white, then we're talking about somebody that's violent, or as you said, wandering patient, which falls under our code yellow. So some of those additional insights as far as how you've been coping with addressing what we consider to be our hospital code system in a non-hospital building for patients.
Yeah, certainly. In terms of the lack of overhead paging, I should have mentioned this, two-way radios. So we procured a large number of two-way radios. We actually had two sets. We had one for strictly the floor that the nurses and staff would wear on their hip. Again, the acoustics in the hotel are awful. If I'm yelling from one end of that hallway, it might sound like the teacher from Charlie Brown on the other end. You won't know what I'm talking about. So the staff have kind of a short distance range radio. And then we also invested in the more higher end, more powerful two-way radios for the building. Obviously, police are called much more frequently to come and support. We do have on-site security. So we have contract security for the hotel. We did do contract security as well for the mobile field hospital. We even had the mobile field hospital did have our own residential conspiracy theorist camped outside for quite some time. That field hospital is right beside our vaccination clinic. So she thought it was a morgue for the people who died from the vaccine. So we did have security and police aware of that situation, but that is a consideration as well. Didn't really come up, but in the heated environment, political environments, and you have a field hospital, and if you get something like what we had, where we had protests outside hospital, you do need to really keep in mind the security considerations for these sites, that if someone really objects to what they think is going on, that they act on it. And so we had pretty robust security, 24/7 staffing. The hotel, thankfully, is a much easier site to secure, especially now that we've installed those mitigative measures and having fob access and and things like that.
We're taking it back to, still got a few more questions, and I will encourage folks again that are still with us attending that we have a little bit more time. You can continue to put a few in the Q&A. Otherwise, I will continue to monopolize, pardon me, Andrew's time with my own questions. I do want to say that somebody did ask if there were examples of frameworks that were developed that could be shared. This touched on perhaps a thought that I had as well, which is, are you building the plane while you're flying it, or were there already some kind of assessments and, SOPs and things like that that had been developed going into this? And if not, are those now things that are sort of established to say, these are some of the guidelines, the frameworks we used, this is how we would use it going forward?
I would love to say that we had SOPs developed beforehand. Quite honestly, and I think this was the case from talking to a lot of colleagues, even pandemic plans, we just kind of threw out what we had and started winging it and learning on just kind of building on the go. We'll work towards building probably some SOPs, mainly for the hotel. I do have some stuff that could be shared for the field hospital in terms of emergency planning and those considerations. But again, it comes down to the type of tent hospital. I know other folks we had a modular tent, which was very useful. I know other folks have had those big, long tents that's just one space. So if you want to talk about fire planning, those are a nightmare because your room of origin is the tent. And so how are you going to evacuate 35 semi-acute people? So I'm happy to I can share those resources, and once I start collating them. But yeah, no, we did not have anything beforehand. I wish we had.
Yeah, no, I'm not surprised. I wasn't trying to put you on the spot.
Oh, no.
But I was curious as far as if some of those considerations had been thought about in advance, and then sort of where you're at now. And since somebody was asking, it was an anonymous Q&A question kind of asking about the frameworks, but I would put it out there to any of the attendees. We're not going to have Andrew give you his contact info. However, if you want to direct your questions to us at CFAL, then we can obviously kind of filter those things. We can help facilitate some sort of contact between yourself and our speaker as far as any of those inquiries for any materials and so on. So, again, like if you are interested, please reach out to us and we'll try and facilitate that ongoing dialogue. I have a very specific question that's fire and evacuation related, and then one that's a little bit more general that perhaps I can kind of answer. So one that we have is more so just around evacuation routes. And so, as you said, so when it's the tent, depending on the type of tent, that's going to change what this is. But as far as with the hotel, there was a question as far as, do you have these different staircases accessible to you? Have they been designated as, one is a responder resource, one is for patient movement, because you don't want to have one blocked, potentially, let's say the fire department by their personnel and equipment. And so I'm assuming those are probably considerations that you've had to consider while you've been developing kind of safety plans for that site.
Yeah, so we do have a primary evacuation stairwell, and then which is our west stairwell, and then the east we've labeled as an alternate, but that would be prioritized for the responders, and then once the responders were on site, if we needed to evacuate patients on that side of the building, we would. And then we actually don't evacuate out of the building. We go to the hotel. Is weird that there's 3 parking levels and then you start the hotel levels. So the first floor on the hotel is actually the 4th floor. So we'd go down to parking level 3, which is where the ballrooms are. Being a hotel and conference center, they do have some very large ballrooms. So we would collect there and then wait for kind of direction from Hamilton Fire, because again, if it's -40 outside, and we don't need to necessarily go outside, the fire is contained just to that floor, then we don't need to necessarily put our patients out in harm's way in downtown Hamilton if we don't have to. So we do have also a staged evacuation process to that.
Yeah, that's great. Just before I get to the last, it's a big ticket question, I think. Is I was just going to ask, as far as, decommissioning. So obviously that's not something that's on the near horizon for your hotel scenario. But something like the field hospital, you discussed that it took about a month and a half to be able to actually get that sort of up and ready to run. How long did it take to actually strike something like that?
Not as long. It came down pretty quick. We cannibalized all the internal resources. So the tent itself was from the company we worked with. So they came in and handled that. The generators were all part of them. The bladder, all the infrastructure support was them. We very quickly cannibalized all the internal resources. There's an extra Omnicell for unit, all the beds, everything, linen carts, all that. We're a fairly older organization, so we've got some equipment that's aged. So we were happy, units were happy to take those off our hands really quick. So I'd probably say in a matter of a couple of weeks, we had the parking lot reopened for staff. It was, and when setting up, we did have to factor the leveling of the field, or the parking lot. So that did add to the lead time into putting it up, but tearing it down much faster.
So the big ticket question goes beyond just yourself or myself or the organizers from this series, is really with the amount of incredible work, to quote here, and knowledge that's been gained throughout the pandemic. Is there advocacy for the lessons learned to be brought to a provincial or federal level? And I'll ask if you have any insight on that, but I know for those on the call that do come from healthcare, recognizing that not everybody who's joined us has, we do at least have our own kind of peer support network that we're able to share. And I find that that's been very valuable as kind of colleagues to be able to, as Andrew said, go from lessons learned to lessons applied. But if you have any insight on this particular topic, Andrew, the question is out there.
Yeah, I'm unfortunately not aware of any. I mean, us as a group in our semi-formal association certainly can and probably should start advocating from a hospital perspective to start collating this. I think what we really need, and I think I was talking to a colleague in the States as well, and they also are lacking this, is similar to what they did with the 9/11 Commission, and is to replicate something like that for COVID. I mean, it was our worst disaster since the Spanish flu. And so I think there needs to be federal initiative to start capturing all the lessons learned. I think there needs to be a paradigm shift in how do we even approach pandemic planning, given how many pandemic plans were just kind of tossed aside initially, because once asymptomatic spread hit, that kind of threw a curveball through a lot of plans. But then that raises the question, the decade prior of planning, if everyone was tossing out their plans or massively adjusting their plans, how valuable was that previous decade of planning? So I think we as a whole, as an industry, we need to look at either a summit and a paper or a number of papers, like a book, a commission report would be ideal. But then I think working with both provincial and federal agencies to get that ongoing support, which unfortunately isn't there. It's something that is needed. I think knowing our community, I think we can make a big push from the ground up. And we can certainly share amongst each other, but we will need our provincial and federal counterparts also to join in the game and start looking at when this happens again, because it will happen again. How we can take the lessons from this, which also shockingly, putting my historian hat on, when you look at how the Spanish flu rolled out, there's a shocking number of similarities and lessons that just were not considered or applied a century later. So
I feel like
yeah,
it's probably a topic for
it's a whole other series could
So,
be just done on
but
that question. So
yeah.
yeah, I think we can advocate. I think we should advocate. And I'm hoping that we start seeing that leadership from upper levels as well to take that initiative.
So I recognize we have just passed time. Before I flip it back to my fellow facilitator on this, Andrew, I want to say thank you very much for joining us today and being a speaker on this topic. Obviously, we had a bit of a pandemic lean because that was kind of the impetus for setting up these two different types of temporary patient housing setups. Very much appreciate your time, and I appreciate you fielding questions so well for the past 20 minutes. So I want to thank everybody else for attending as well. I don't see any other questions at the moment, but lots of gratitude for you sharing your insights with us. And at this point, I'll flip it back to Francesco to close us off with the last minute here.
Perfect. Thank you so much. Thank you, Andrew, for that great presentation and for answering all the questions. Thank you, Mesha, for moderating and helping with the entire series as always. And I just also wanted to thank you both on behalf of Dr. Asghari, who had to run to another meeting, but asked me to thank you both on his behalf as well. And of course, thank you to everyone who attended today and who was participating in the chat and asking questions. Thank you very much for taking the time to be here and to participate and be part of the conversation. So with that, I'll just really quickly share my screen to show the next session that we have coming up. So if you can see that okay, we just have our next session. Again, this is, as most of you probably know, it's a monthly series, the first Wednesday of every month. So our next session will be Wednesday, November 1st at the same time, 12 o'clock Eastern time, where our speaker will be Tammy Ryan from the Seoul Area Hospital, who will be speaking on Code Silver, weapons threat, and active killers. So if that is of interest to you or anybody you know in your network, please mark that date on your calendar. If you're already registered for the series, then you will get the weekly and reminder and the reminder for the day before the session. And again, registration is always open until the very last session. So please feel free to share it within your networks and let's get more people involved in the conversation of these important topics. So with that, I'll thank everybody again. And I think we can end it there.